On today's episode of 26 Minutes with Dr. Warren Seigel on the Zurmed Show, we're diving into an incredibly important and vital topic: substance use and abuse. We will explore the complexities of substance abuse, its impact on individuals, their families, and on communities, and the latest advancements in treatment and support. Stay with us for an insightful and thought-provoking discussion on this critical issue. I'm your host, Dr. Warren Seigel. Joining me are two of my esteemed colleagues, Sal Florio, the Director of Mental Health Services, and Lucille DiGennaro, a dedicated Clerical Associate in our program. Thank you both so much for coming on the show today.
Thank you for having us, Dr.
Thank you.
So Sal, why don't you tell us a little bit about yourself?
Sure. I was born and raised in this immediate area, actually about 10 blocks from this hospital. I am an avid music fan, music aficionado. I play guitar in my spare time. I am an avid walker. Over that past few years, I make it my business to try to walk at least my 10,000 steps every day. I've been in the field of substance abuse and mental health and HIV treatment for the past 30 years. I joined South Brooklyn Health in 2005 as the director of the substance abuse treatment program. At that point, we had 4 programs, one being an inpatient detox. Over the years, the service has grown and changed. Currently, we have an outpatient program and inpatient services. And my responsibility is basically clinical and administrative oversight. I'm a social worker by training. I'm a Clinton social worker by training. And prior to coming to South Brooklyn Health, I worked in the Montefiore system for a number of years and some other places that were very important over the course of my career. So thank you for having us.
With so many places that you've worked and so many years that you've dedicated your professional career to substance use, can you talk a little bit about how treatment has changed, how screening has changed over those years?
Yeah, it's changed tremendously. When I came into the field, it was in the mid-1980s, and we were in the midst of the HIV epidemic, and also the crack cocaine epidemic was rampant at that time. The primary modality for treatment at that time was residential, both long-term and inpatient rehab programs, and the focus of treatment was primarily individuals who were motivated to be into treatment. So there was a sense folks who had hit bottom would come into the program. It's changed tremendously, starting with the HIV epidemic, where the focus became harm reduction and helping folks to stay safe. So the initial change was accessible, safe, sterile injecting equipment, and now working with individuals who may not be ready to change and have different goals and objectives other than pure abstinence as a treatment model. And then I would say, particularly in the past few years, an incredible problem of opiate overdose and educating and training the public on how to prevent an overdose and available Narcan.
So when we talk about substance use and abuse, are we just talking about alcohol? Are we talking about heroin? You mentioned crack, cocaine, opiate. I mean, really, what are we talking?
We're talking about all of those, all of the above. And diagnostically, a few years ago, DSM changed to move away from addiction, chemical dependency, and characterized this problem as a range of issues from use to excessive use to habitual use to the point of physical dependency, and each of those having appropriate responses. So if it's alcohol, it can be benzodiazepines. Right now, the big problem is opiates. And then combinations of those that are done together, which would increase, the danger.
use the term DSM. Could you explain what that is?
DSM is the Diagnostic and Statistical Manual. It's put out by the American Psychiatric Association, and periodically it undergoes revisions. And in the last revision, they moved away from chemical dependency, and all of the diagnosable illnesses are substance use disorder. So if it's alcohol use disorder. If it's opiates, it's opiate use disorder. If it's cigarettes, it's nicotine use, whatever it is, and then the severity and the amount that's being used. So someone may be using, maybe, in early remission and maybe long-term remission. And each of those, it's a more accurate way of capturing what's going on. Most individuals don't start out fully addicted. They start out as oftentimes casual users and then progress along that until, dependency, which historically is when they would enter treatment.
So it sounds like there's a continuum here. I start eating and I can't stop and I am overweight. I mean, that's how I think of substance use. Is that a reasonable way of thinking?
Absolutely. But the other thing that is important to keep in mind is that, and I believe it's a disease, because of controversies, it is not a disease. And in the medical world, it's accepted as a disease. One of the essences of this particular disease is that it's a chronic disease, and that there are periods of long-term remission followed by sometimes relapse, and like diabetes, like coronary heart disease, like cancer, it's multifactorial. There's a behavioral component, sometimes there's a psychological component, there's a community component, and there's the physical component as well. So all of those are extremely important.
And you mentioned the DSM, the Diagnostic Statistical Manual. I always think of that in psychiatric departments, right? Is this a psychiatric disorder? Is this you mentioned physical?
It's everything. It's, we sit within the Department of Behavioral Health, so our department is in that category because it's considered one of those conditions, but it's at least as much a physical condition for those who have it as a psychiatric condition. And complicated further by the fact that such a high percentage of folks that we see have another mental illness in addition to substance use.
So that's interesting. Can you speak a little bit more about that? What is that interaction, for lack of a term?
So
is it if I have a psychiatric diagnosis, am I more likely to have a substance use problem, chicken or the egg?
Yeah, so we don't know if it's chicken or the egg, and that, we've gone back and forth, but it can start in either direction. But once it's there, someone could have an anxiety disorder, clinical depression, and substance abuse disorder. They both have to be treated simultaneously. So in the old way of doing things, if someone had a substance use disorder and they went to a substance abuse, they had a mental health disorder and a substance abuse program, and they went to a substance abuse program, they'd say, well, you got to go fix your mental health problem. Go to a therapist, go see a psychiatrist, get on medication, and they come back. And on the other hand, it would be the same thing on the mental health side. Someone would come in with a mental health diagnosis and substance abuse, and they would be told, you got to be clean before you address your substance. That's not happening, but historically, that is what happened. And the belief now is you have to treat both, or you're not going to have a good outcome.
So is the treatment now, after all the years you've been doing this, are we at a point where you're now saying, no, we don't say we treat one or the other, we treat holistically, comprehensively, psychiatric problem as well as substance use?
No, I think the best programs approach it from an integrated model. So they'll have a staff, and on that staff, they'll have addiction counselors. They'll have trained mental health professionals, usually a psychiatrist, maybe a psychiatric nurse practitioner. There may be some peers, because clients with substance use disorder tend to relate better to someone that they identify with. And so peers are very, very important. And medications. Right now, medications are critically important when we're talking about opiate use disorder. And there are good medications. There's still a lot of stigma associated that I think is a continued challenge. But for instance, buprenorphine, methadone, naltrexone, each of those are treatments for opiate use disorder. And naltrexone is also used for alcohol use disorder, both orally and injectable would be Vivitrol.
Sounds incredibly complicated.
It is.
Sounds very complicated.
It is.
So, Lucille, tell us a little bit about yourself. How did you get involved in the substance use disorder world and treatment?
Well, it's more of a personal story for me. My 19-year-old daughter became addicted to heroin. And when I had found out, I was absolutely terrified. I didn't know what to do. I couldn't grasp that this was happening to her and to me, because as a parent, you need to help your child, and you don't know what to do. The minute you find out you're in this tailspin, you're basically like, you're useless to them, because your mind is in such a jumble. There's no clarity. All you keep thinking is, I must help my child, I must help my child, but you don't know what to do. I was fortunate enough at the time to, I was directed to a family support group. And I went to the group and I was given tools. I learned how to help her. I learned the direction to go into. I was given hope. That was so important to me, because when I first found out, to me, this whole situation seemed hopeless. You know, I had the same vision as other people. Oh my goodness, she's a heroin addict. I've seen that this is such a long-term thing, and I didn't know that, yes, there is help out there, and yes, she can go into recovery. And within the confines of this group and counseling, I was able to help her as well as myself, because as a parent, you need help too.
Thank you so much for sharing that. But at 19, your daughter was 19, she became a heroin addict. If you don't mind my asking,
Yeah.
what something must have led up to that, right? I mean, I heard that this is a continuum. Again, in my mind, I think about, I start eating, and then I can't stop eating, and then I just get overweight, and I'm overweight, so therefore I'm more hungry, so, you know, it just gets worse and worse. People don't start using heroin. Do you have a sense to what was your daughter going through, and how did she get to heroin?
So my daughter suffered from severe anxiety her whole life, and she was always looking for a way to cope with it. I had taken her to many doctors, many therapists, psychiatrists, but for some reason she just would not follow the program, or she would just quit and say, they're not helping me, I can't get past this. And I saw that her issues were getting worse and worse. Her anxiety was getting so where she never even wanted to leave the house. So I do know that a friend introduced her to, I believe it was Percocet. And I know she started with that. And this was all within a very, very short period of time. I would say the whole thing was within 2 months. And from what I understand, she couldn't get the Percocet anymore. And she was introduced to heroin. It was a cheaper way. And she was able to numb herself for a little while. And, you know, that was basically, it was all within a very, very short period of time when this happened.
So it sounds to me like this is a great example of that psychiatric issue.
Yes.
Yeah.
Turning into substance abuse or use and then abuse. And I'm sure there are plenty of people who start with substances and develop a psychiatric issue because of their substance use. Are there things that you as a mom, me as a dad, all of us should be on the lookout for, that we should think of and say, wait a minute, my loved one, fill in the blank, has a problem. Is it just because they have anxiety or depression that we should worry about a substance?
So it's my belief, there are a lot of individuals that during the formative years experiment with substance abuse. They experiment with alcohol, they experiment with marijuana, but oftentimes it's the individuals that have underlying mental health issues that when they try the substance, it's almost like they get that relief. They get a sense of relief. If someone has really severe anxiety and they happen to try a Valium or they happen to try Xanax, they're going to get relief that they're not going to get from the psychiatric medication. Unfortunately, that becomes a real challenge. The same thing with heroin. If someone is in all kinds of emotional turmoil in their adolescence or whatever, and they try the substance, there's a percentage of people that will become physically addicted. Predicting who will or who won't, I think is really, really challenging. Right now, I would say there are more individuals because of the opiate situation who are going directly to opiates and not necessarily in the same way that it was when I started doing this work. So someone would try marijuana, they would try something else, and then, again, some would go to heroin. Like Kelly, who went to Percocet, and then from a prescribed pain medication, went right to heroin, kind of is a different thing. So I would say for parents to just, pay attention to who their friends are, pay attention to changes in behavior, try to have a meaningful, honest ability for your kid to be able to disclose to you. My experience is that parents are always the last one to know. And when they see it, oh my God, how come I didn't notice? Yeah. Like all the signs were there. What was I thinking? And then there's this guilt that they experience, which is unfortunate because there's really no way to know. But I think, having a strong family communication system is incredibly important.
So what are the signs and symptoms? I'm thinking of my own kids. What are the things that I should be looking out for? You mentioned friends. Well, I know some of their friends, but I don't go to school every day and sit with them. I don't know. I only know the friends that they introduce me to.
Right.
I don't know all the kids that they don't introduce me to. I don't know what they're doing. I can't watch them 24/7 or live.
Yeah.
What are the signs that my son, my daughter, or my husband, my wife, or my parents might have a substance abuse?
I think for kids, it's changes in behavior, like during adolescence. So, like change of friends group, decrease in, performance at school, any kinds of problems with truancy, anything, like that. Change of interest. I mean, it's not something like you could scientifically say it, the kid is doing this, that, or that. It's more a profile that develops. And, yeah. So, I don't know if that's a good answer.
There's no sign, there's no symptom.
Well, once they're using, if they're using opiates, you'll see decrease in evidence to sedative. You'll see.
When you talk about opiates, could you be specific? What are the opiates that people are using? And I don't want to make this just about kids. I mean, with all due respect, Kelly was 19, not really a kid. I think of kids, I think of 12, 13, 14-year-olds. A young adult, really. And there are plenty of adults, I would imagine, that develop substance abuse disorders, right?
Right. So all of the opiates are derivatives of opium. First being morphine, heroin, and then there are synthetic opiates, things like hydromorphone, oxycodone, that are pharmaceutical analgesics that are prescribed medications for pain that people take for legitimate reasons that cause tolerance. Always. So for someone who is on an opiate, over time, the opiate doesn't have the same effect, so they end up taking more of it to get the same desired outcome. So right now, the big problem is fentanyl.
So this is why, for my arthritis, I go to a doctor and they prescribe a medication. I could actually be addicted to that medication.
Right. But you'll notice now, because of all of the focus of attention, there's something called the prescription monitoring system, which is iStop, that every time a pharmacy writes a prescription fills a prescription for an opiate, it goes into the database, because he used to have patients who were doctor's job. So they would go to Dr. A, they would get a prescription, and they would get 30 or 60 Percocets, and then they'd go to the next, down the street to the next doctor, and they'd get it, and no one knew. Now it's very difficult to get opiates prescribed more than a few days, unless someone has, a real bad illness.
So we're not, I don't want to talk about those people who need this kind of medication for medical reasons. I'm really talking about people who are abusing medication. So I assume they're not going to CVS, they're not going to Duane Reade, they're not going to a local pharmacy. Is it that easy to get these kinds of drugs on the street?
It's very easy right now. Yes, it's very
These
easy.
opiates are that simple to get.
Yes.
Heroin was that easy for people to get.
But heroin now, the majority of the heroin that's in New York City is not heroin, it's fentanyl.
Can you explain? I hear about all the people who are dying because of fentanyl.
So fentanyl is the most powerful synthetic opiate. It's reported to be 100 times more powerful than heroin or morphine. And on the presentation we do, it has a picture of a penny, and there's a tiny, it looks like a little bit of salt. That's a fatal dosage of fentanyl. And it's in all of the drug and heroin supply in New York City and around the country. We've even had it reported in cocaine. We've had it reported in street Xanax. That's actually not Xanax, but it's actually fentanyl. And we've had reported cases of marijuana.
So not only do we have a substance problem, but we've got fentanyl being put into the substance to it's killing me. Is that what I'm hearing?
Yeah, and that's why I right now the focus has changed, not just to help individuals to get off substance, just get them to save their lives. So if I may, we have this, which is extremely effective. This is Narcan. And what it is an antagonist that would knock opiates off the receptor. And if someone was in a potentially situation where they could go into an overdose, one spray of this could reverse them, could reverse the overdose. And most substance abuse programs now in New York are distributing these, and the police now distribute them. They've been available since 2014, but in the past few years, they're widely available. And this particular kit is 4 milligrams of Narcan, which was increased, used to be 2, and they increased it to 4 milligrams because the fentanyl was so powerful. Some people needed 2 dosages to respond.
This is what everybody's talking about, naloxone, right?
This is it.
Naloxone, that's it. Yeah. So I can have this. I don't need to be an EMT. I don't need to be a paramedic. I don't need to be a doctor or a nurse. I can take this.
Yes. And what happens is there's modifications in the Good Samaritan law that went into effect in 2014. If you use it and God forbid something, then no one can sue you or anything like that. But these are completely safe. If there's no opiates in the system, it's just like someone had a spray.
So if I took this and I shoved it up my nose and I had to spray it, nothing would happen.
Nothing.
But if I were using fentanyl,
if you had opiates in your system, it would jump onto the receptors, any opiate, and it lasts to 30 to 90 minutes. So we educate people to make sure you still go to the emergency room, because if it wears off and the person has enough drugs in their system, they can still go into an overdose.
So this could save somebody's life.
Absolutely. Yes.
Incredible. So tiny. So tell us a little bit more about what has been your experience being the mom of a substance user.
Being the mom of a substance user is very difficult. It's absolutely terrifying. But like I said, when I became part of this group and I was given direction, I was able to get Kelly into treatment. And she did well for a while. But unfortunately, she decided to try it again one more time. And that was her fatal overdose. So, and being part of this family group that I still continue to go to afterwards is basically what helped me get through all of this. Their support and their inclusion and letting me stay with them and just getting me past this horror was wonderful. I can't tell you how important that was to me.
I'm so sorry.
Thank you.
I don't know how anybody gets over it. I don't know how anybody moves on. I don't know how you even get up the next morning and breathe.
Do you want to hear something interesting, Dr. Seigel? So when Kelly first passed away, the first night I didn't sleep, but the second night I got a little bit of sleep. And I woke up the next day and I was like, God, why am I here? I don't want to be here. My little girl is out there somewhere by herself. I need to be with her. She was always by my side, and how am I letting her go into a place all by herself? And I would wake up every day with the same question, why am I here? They don't understand it. I have to be with her. But the thing is, you wake up every day. There's another plan for you. No matter what, you're there every day. You open your eyes in the morning and it's like, okay, I'm here. There's got to be a reason.
Well, I would like to think that the reason you're here is to be able to do this.
I absolutely.
And I want to thank both of you.
Thank you.
For being so open and sharing your experiences. Thank you for the work you're doing every single day. We've got to get naloxone in everybody's hands throughout the city. Everybody should have it in their car, in their medicine cabinet. We've got to save some lives. And that brings us to the end of our programs today. We sincerely thank you for tuning in and learning alongside of us. For more information about our show, please don't hesitate to call us at 718-510-2103 or visit us online at www.zurmed.com. Stay updated and engaged with South Brooklyn Health by visiting our website at www.nychealthandhospitals.org/South Brooklyn-Health. This broadcast was proudly brought to you by Brick Media in partnership with South Brooklyn Health. Until we meet again, stay informed and please stay well.